Um, Welcome and thanks for joining us this afternoon. We're so fortunate to have Susie Keller. And Susie, can you pronounce the middle part of your name for us?
Sure. Susie Pouliot Keller. I'm the
Julia.
CEO of the Idaho Medical Association. Happy to be here.
Thanks, Susie. And Mike Cunnington is with us today to give us an update. Both of them will be giving us an update on the legislative session related to healthcare. My name is Katrina Hoff. I'm the director of Southwest Idaho Area Health Education Center, and I have pasted something in the chat regarding our disclosure that neither Susie or Mike have any relevant financial relationships to disclose. And if you need to record your attendance, the code is there. And please, please, please complete the post-session evaluation because your feedback is important to us and it helps us improve. And thank you so much. And with that, Susie and Mike, I will let you go ahead and get started.
Thanks so much, Katrina. Very much appreciate the opportunity. And it looks like we're kind of a small group. So given that, if you all have questions or comments that you want to chime in and share with us as we go through, uh, please feel free to do that. Um, we'll just jump right in, and we'll go over our agenda here. So these are the things we are going to talk about today. But before we get into that, I just want to take a quick moment and talk about the legislative environment. There was an election in 2024. So that means in 2025, we have a lot of new legislators. In fact, we had close to a 40% turnover of some of our folks. So that means a lot of new faces. It also means new committees in terms of makeup, new committee chairs, and in the case of the Senate, new leadership. So a very different legislature than we had been working with for the prior 2 years. And that creates some challenges with folks just coming in that maybe don't have a background in healthcare, that sort of thing. So a lot of education needs to be done by health advocates to make sure that we're getting people on board. So sorry, I'm having beeps in the background, so I'll try and mute that. But just in that landscape, a little more challenging environment for healthcare advocacy in 2025. So I'll pause there and ask Mike, did you have anything you wanted to add in terms of the general legislative environment?
No, I think that outlines it very nicely and kind of encompasses some of the additional challenges that we faced this session.
Great. Okay. So as you can see on the screen, the IMA had our priorities coming in. And for those of you who are familiar with the Idaho Medical Association, these aren't going to be shocking new developments. We've been working for a while on improving the abortion ban and making sure that pregnant women can get care. We had a new bill come up last year that really hinders the ability of healthcare providers to treat minors in certain situations. Again, for Medicaid expansion, a long-time priority, so trying to preserve that. And then our ongoing goal of expanding residency training, graduate medical education opportunities in the state of Idaho. And then we'll touch on some other issues as well. But if folks have any specific questions about issues or bills that we don't cover, please throw them in the chat or ask us a question and we'll be happy to cover those. So with that, we will dive right in and we'll start with talking about how we are trying to improve the abortion ban and its impacts on patient access to care. So as I think most folks know, we have been working to make changes to our law to make it legal for physicians to provide standard of care treatments for women who are pregnant experiencing health-related issues as a result of their pregnancy. And there's some examples there. And this is something that unfortunately the current law does not cover. And so something we have been trying to bring focus to for the past couple of years. So next slide, please. And as a result, so when somebody is experiencing a pregnancy complication that impacts their health, a lot of times our physicians can't intervene. So therefore, those folks are experiencing delays in getting their care, and it does have long-term implications on their health or even jeopardizing their future ability to have children. And unfortunately, physicians are caught in this difficult situation between federal law, EMTALA, that I think most folks are familiar with, that requires emergency stabilization to preserve the health of folks, and then state law where no exceptions are allowed. So please go ahead to the next slide. And so therefore, it's really had an impact on our access to care. And in 2023, Idaho unfortunately saw the departure of several of our OBGYN physicians. About 22% of them left the state, stopped practicing, et cetera. And we lost more than half of our maternal fetal medicine specialists. Right now, we know that there is a follow-on study that looks at the 2023 to 24 numbers. And although there has been some backfill of some of those positions, we believe that there's still an overall loss of providers from the state. And clearly that has a lot of impacts on patients being able to access the care that they need in their home communities. You can see here, 3 hospitals have stopped providing maternal fetal care, labor and delivery. And that really creates a lot of challenges for patients who are trying to have babies in the state of Idaho and get care in their home communities. So next slide. So our focus has been on this emergency medical exception because it really would create a lot more access to care, lower the level of fear that providers have in treating these. And as we do every legislative session, we go in and hit the ground running and with our advocacy efforts. And we felt optimistic in January, and unfortunately, due to some litigation that was ongoing, many legislators had been cautioned to not legislate in this area because it could adversely impact litigation. So folks became less willing to engage in that. However, towards the end of the session, it was good news. In March, Senate Bill 1184 was introduced by Senator Jim Woodward and Mark Sauter from the Sandpoint area, one of the impacted parts of our state. And it would have provided that emergency medical exception and an additional exception for cases in which the fetus has a condition, an anomaly that is inconsistent with life outside the womb. Unfortunately, this was just an informational hearing and it did not move forward for a vote. Next slide, please. I had mentioned some lawsuits. 2 of note have recently had action. Under the former administration, the U.S. Department of Justice had sued the state of Idaho for its conflict in our law with federal EMTALA law. And with the new administration coming in, it was anticipated that the new DOJ would drop that lawsuit. So in anticipation of that, St. Luke's Health System sued the state of Idaho for that same conflict and requested a carve out to provide EMTALA coverage and care in Idaho hospitals. And The DOJ on the US side did ultimately drop their case. And on March 20th, there was a ruling in the Idaho case that said, yes, we will grant an injunction that folks can provide EMTALA care for patients, but it's only in St. Luke's facilities because St. Luke's are the only ones that sued. And so no other hospital in the state of Idaho has those EMTALA protections currently. Then in the next month, there was another lawsuit that had a ruling. This was Adkins versus State of Idaho. This was a case that had 4 plaintiffs, patients who they and their families were adversely impacted. Their pregnancies were adversely impacted by Idaho's laws. And they sued along with a couple of physicians and the Idaho Academy of Family Physicians. And that ruling came out and it gave some partial relief. And you can see the actual language of the ruling here. And it's a sliver more than they have been able to do. And attorneys are still processing this and its impact on the current care delivery environment. But it increases the amount of judgment that the physician can use if a pregnant patient's condition could ultimately lead to her death, and that it doesn't have to be imminent. So this case can be appealed, and the deadline for that appeal is May 23rd. After that passes, we'll have a clearer picture of the impacts of this ruling on care delivery in the state of Idaho. Next slide. Okay, so what is next? You may have heard that the Idahoans United for Women and Families is moving forward with a ballot initiative. And that ballot initiative is seeking to restore full reproductive rights to Idaho folks. Not only for abortion, but for fertility treatments and contraception as well. So right now they are in a situation where they are litigating over the long title and short title. Hopefully soon they will hear from the Idaho Supreme Court. And once they have that final court ruling on the final short title and long title, then they will collect signatures. So the process will be, they're going to start to collect signatures. We'll do that through 25. There's a deadline in April of 2026 and all the certifications that go along with that. But their goal is to have that ballot initiative on the general election ballot in 2026. As far as the IMA goes, we will continue our advocacy. Regardless of what happens with the ballot initiative, we still need more clarification in the law around medical emergencies for pregnancy complications. And so we'll continue to keep working with legislators. They are very much aware of the ballot initiative as well. So we'll see what happens there. And then, as I mentioned, we have this updated workforce information that we anticipate being published hopefully in the next several weeks or months. All right, next.
I'm
Over
sure,
to you, Mike.
oh, thank you. I'm sure many of you have heard about the changes to parental rights in the state of Idaho. But as a quick refresher, during the last legislative session in 2024, the Parental Rights and Medical Decision-Making Act was signed into law. The legislation required parental approval for medical treatment for all minors with very limited and narrow exceptions. Oops, what happened here? Oh, sorry about that. Last session, we tried to, warn and educate legislators of some of the unintended consequences that the legislation would bring. But the legislation moved quickly and swiftly through both chambers and into the governor's office. So following that decision, or following that being signed into law, we started getting to work with our partners and stakeholders to prepare for any unintended consequences, document those, And within, a month or so of the legislation going into effect, we started to hear stories. There was one that made the news pretty publicly, where police were going on the record talking about difficulties that they had in pursuing evidence after sexual assault situations with minors, and the parents denying that evidence being collected. We heard from a number of our members that there were multiple cases where parenting minors were able to consent to their newborns' health care, but needed their mom and dad to sign off on their care. Negative issues with mental health as well. During our House of Delegates meeting, our members kind of gave us the direction to focus in three different areas. Creating exceptions for pregnant and parenting minors, mental health exception, and then that, the ability to collect the evidence where there's been an allegation of a crime. So we continued that work through December, and then in January started working with the bill sponsor that introduced the legislation originally. And in March, we're able to introduce Senate Bill 1199. All three of the areas of interest, policy directives that we had from our members, that was all included in the legislation. And it also modified the emergency standard, which was incredibly narrow. Loss of life or permanent disability. It's more or less what that exception was on the emergency side. We had also we started hearing stories at the beginning of 2025 where newborns were being denied treatment for the mother substance abuse, and specifically citing that the law did not allow the physician to treat that baby that was going through withdrawal. So we were able to get that language also included. And then we had a specific carve out for the Idaho Crisis and Suicide Hotline. They had been severely narrowed with the work that they were able to do with minors that had contacted them for help. A few days before the session adjourned, we felt like we were in an okay, just to good place. The legislation had just cleared the Senate, made its way to the House, and ultimately it was held in the House Judiciary Committee. There were a few conservative organizations who had disagreements and conflicts with the bill, specifically in the pregnant and parenting minors portion, and there was also language that it would allow pregnant minors to seek care from a crisis pregnancy center. But the way that language was drafted, it also applied to Planned Parenthood, and that's kind of a non-starter for some of the conservative folks. There were a few conservative organizations that were totally fine with both of those provisions and okayed it in the Senate. But we had some folks that kind of came forward last minute and stopped that. So the bill was ultimately held in the House Judiciary Committee. And our next goal is just continuing to march forward to the next session, educating legislators on the negative impacts of the original bill, additional unintended consequences, and just making sure that those stories are told in public. The next priority that we had is defending Medicaid expansion. There were a couple proposals early on in the session, House Bill 58, which would have just completely repealed Medicaid expansion and did not provide any new and additional coverage for safety net transition. The bill didn't make it out of committee, ultimately held in the House Health and Welfare Committee. House Bill 138 was introduced a few weeks later. It had similar legislation that was introduced in 2024. But it creates 11 different waivers or would have created 11 different waivers to the Medicaid expansion population, in an effort to limit the number of folks that participated in the program. The problem with that legislation, ultimately, is that if any of those waivers were denied on the federal end, overturned by court decision, or maybe the Idaho Department of Health and Welfare didn't get the waiver submitted properly. In any of those situations, it would have repealed Medicaid expansion and disenrolled 90,000, 85,000 members or individuals from that coverage within 90 days. So pretty bad news. That legislation that was introduced last year ultimately never cleared the committee. But as Susie was explaining, through the new committee alignment process, they kind of stacked the deck to get Medicaid, to address Medicaid expansion, Medicaid reform. So the committee in the House Health and Welfare ultimately ended up passing the bill by one vote. From there, it cleared the House quickly and made its way to the Senate Health and Welfare Committee, where it was held initially. Probably would have moved forward with the committee hearing had it not been for the bill that ultimately ended up being signed into law, which is House Bill 345. This legislation it was just a complete overhaul of Medicaid. It attempted to do that in two different areas. The first area being those waivers that we were talking about before. It would put into place 3 different waivers that the department is working on currently to process. One would be a work requirement waiver. The second is a choice waiver that would allow qualifying individuals to decide between a premium tax credit to purchase a plan with Your Health Idaho Exchange, or choose a Medicaid expansion plan. And then the third waiver is to implement co-pays as a condition of participation. So those waivers are in process of being submitted by the department and will make their way over to the feds. I wouldn't say soon, but at some point. Then the second larger transition will be moving from value care based reimbursement for Medicaid to Medicaid managed care. And that has been an ongoing topic of conversation for the last 2 or 3 years. There was a movement to try to go that direction in 2023. It ultimately was kind of held back and stopped. And then it was tucked into this bill and quickly introduced and moved forward during the session. Since it has been signed into law, we've been working with a number of our members and individuals that participate with the Healthy Connections portion of the valued care reimbursement. And a number of practices are sharing the number of Medicaid patients that they currently see, and the funds that they are potentially going to lose at the end of the year. when the value care transitions out and additional conversations for managed care move forward. So far, we've heard from approximately 13 or 14 practices throughout the state, and there's a substantial number of patients that could potentially be impacted with coverage. Right, currently upwards of 50,000. As folks start to assess, what they do with the change in those Healthy Connections case management funds. Susie and I have been involved in stakeholder meeting groups, kind of sharing that information and working with the Department of Health and Welfare and other stakeholders to provide feedback and direction as we move forward. There is a Medicaid review panel that will also be very important in this process. It consists of 11 legislators, mixed almost evenly in the House and the Senate. And the department will be presenting information to them on a regular basis to provide feedback from some of our conversations and stakeholder conversations on just what the next step forward looks like as we move into this managed care world. I think the current plan, it sounds like, will be 2 to 3 different MCOs in the state, and those MCOs will have coverage throughout the entire state. So a lot of unknown there, and it sounds like that review panel will be making its way throughout the state to do regional meetings, to get feedback from folks on the ground there.
Okay, shifting gears to another one of our longstanding priorities, which is GME expansion, graduate medical education or residency training, that step after medical school that determines what type of physician the graduate is going to be. And the 10-year plan was first implemented in 2018, and we are very grateful that the legislature year after year has provided state general funds to help expand our training programs. And so this is what the strategic plan contemplates as the goal. More training throughout the state, and especially in rural areas. Increasing our GME programs throughout the state, increasing the number of residents and fellows, and then trying to increase our standing among other states in terms of our residents that are training per our population. So the goal is to graduate 2,000 additional Idaho trained residents at the end of the 10 years. So looking into the economic impact, this data is a little old, but we still include it because it's quite impactful. And just to remind folks, especially legislators, that each practicing physician in Idaho supports an average of 12 jobs, both directly and indirectly, produces almost $2 million in economic output, and generates a lot of state and local tax revenue too. And that's, of course, over and above the community impact of people being able to get care in their local communities. Okay, so year 8 of the plan, and this was House Bill 333, and it contemplated 14 new residency positions in family medicine, internal medicine, psychiatry, and family medicine. I may have already said that, apologize. And in addition, so that was the governor's request, these 14 new slots at the 60,000 per seat level. The Idaho state government pays for a third of the cost of training a resident. The residency program itself and its sponsoring institution also contribute to that cost. And fortunately, the legislature went over and above the governor's request and provided additional funding for a child psychiatry fellowship in Eastern Idaho. So we are very pleased about that. And in addition, JFAC also put intent language in that legislation to encourage the prioritization of OBGYN fellowships in our family medicine residency training programs. And I think that's a significant piece of the message that JFAC is trying to send, which is we acknowledge that there is a physician healthcare workforce issue in the state of Idaho, specifically around women's healthcare. And so we would like to ask the residency programs, please prioritize your training and report back to the legislature how that can be bolstered and what the state can do to help support that. So all in all, we came away with 20 new seats because there were an additional 5 seats that were fully federally funded. So we continue to make good strides forward as far as our GME expansion is going. And I will just say on the topic of GME, this is an important part of the pipeline for Idaho. And one of the ways that Idaho actually excels among other states in the country, we rank in the top 5 of states, I want to say, in terms of retaining our residents who train here. So most of them are likely to stay and practice here. So we know if we can get more residency training opportunities, the likelihood of them staying and being a part of our physician workforce moving forward, those odds are very good. And so this has been a priority for a lot of folks. And again, fortunately, something that the legislature has also year after year put their funding priority behind as well. So I will shift gears and from there, talk about WWAMI a little bit. Every year at the legislature, IMA comes in with our priorities and the things that we want to proactively work on. And every year there's at least one issue we had no idea that was about to sideswipe us. And it really takes up a lot of time and energy and our resources. And this year that issue was WWAMI and efforts by some legislators to end this longstanding, very productive relationship that Idaho has had for 50 years. So in January, we learned about these efforts that were starting to percolate. And then in February, House Bill 176 was introduced by Speaker Mike Moyle, along with Representative Dustin Manwaring and Senator Dave Lent. And what it did was eventually phase out Idaho's relationship with WWAMI, closing that campus and then pivoting and starting a new expanded relationship with the University of Utah, with the intent of the majority of that training to be done in the state of Idaho. It very quickly passed the House Education Committee, but it didn't come forward and was given a hearing on the floor of the House. And a lot of education stakeholders were looking at this and were very concerned because of the logistical impossibility of standing up a new medical education training system within the state of Idaho if WWAMI had gone away. Because WWAMI over 50 years has built up a very robust network of clinical training sites throughout the state of Idaho. And if the WWAMI program went away, a new program would have to reestablish those clinical training sites with those folks, and would have probably been impossible to accomplish in the time frame that was contemplated. Also, not to mention the huge outcry from a grassroots standpoint of folks that are current or past participants of the WWAMI program, community members, and just how much the WWAMI program has brought to the state of Idaho over this time. Because the University of Washington School of Medicine is one of the premier medical schools in the state. So a huge grassroots backlash was happening at that same time as well. And so moving forward, can you hit the next slide, please? Thanks. In March, a new bill was introduced in recognition of a lot of that logistical concerns and grassroots pushback. House Bill 368, introduced by those same stakeholders, and it is asking for 10 new seats for our undergraduate medical education program in the state of Idaho, but it would be to a non-WWAMI program. And it instructs the State Board of Education to create this undergraduate medical education committee to talk about the future of medical school training in the state of Idaho and considering its impact on the physician shortage. And additional work with stakeholders did ultimately result in the bill not providing any cuts to WWAMI seats. So that program remains intact, which is a very good outcome. The Idaho State Board of Education does have a GME committee. They are the ones who have been responsible for the 10-year plan and the coordination of all of those program directors in proposing and implementing the plan. And so having an undergraduate medical education committee along those same lines is something that many stakeholders have thought was a good idea. So this is a positive step moving forward. The Idaho Medical Association is very heavily involved in both of those committees. And so we feel like this is a good step forward and making sure we're looking at all parts of the physician training pipeline and making recommendations to the legislature on where resources should be allocated. And Mike, before we shift over, I just want to say, since I'm talking about the physician training pipeline, another really important part of that is our practice environment and recruiting and retaining providers here in the state after they've completed their training. And a big part of that is our loan repayment program. In Idaho, it's known as RPIP, which is the Rural Physician Incentive Program. And I see Amy is on the program today, so shout out to her for her work with that program. But this is a very important part of our physician workforce training pipeline because it provides that loan repayment incentivized for primary care folks who will practice in rural and underserved communities. And Governor Little, in recognizing our physician workforce challenges, did include an extra $500,000 budget proposal in his recommendation to the legislature. And we were very disappointed that ultimately the legislature did not approve that extra funding. Fortunately, they didn't touch the existing funding model, but that's something that I hope we will revisit. And we know that the governor remains supportive of that program. So hopefully we can look at that in the future. But I just wanted to mention that as another one of our legislative challenges this year. So over to you, Mike.
Next, we have the Medical Ethics Defense Act. This is actually the third session in a row that the legislation similar had been introduced, and kind of continues this national trend aimed to protect healthcare providers who refuse to participate in medical procedures that conflict with their religious, moral, or ethical beliefs. So in 2023 and 2024, we had received kind of some cookie cutter language that a national organization called the Alliance Defending Freedom had introduced in other states. We attempted to get that language modified, and ultimately none of the changes were adopted. Fortunately, we were able to kind of keep those two proposals at bay and stop them in 23 and 24. But this session, we caught wind early on that another legislator was going to be running the legislation. And he typically gets his stuff across the finish line and signed into law, and really works super hard to get that done. Fortunately, he had reached out to us very early on and asked for some potential changes to the bill. And so, knowing that there was a very, very strong chance that the legislation would make its way through, we wanted to try to take him up on that offer. And he ended up accepting all of the changes that we had submitted, and we feel pretty confident that with those changes, the legislation is not going to be impactful from a practice side. So those changes include, requiring employees to disclose their conscious-based objections as soon as possible, and they can be asked for in writing at the time of hiring. An employee also has to be able to complete the essential functions of their job duties. And if they can't, the employer can then reassign the employee to continue just the normal general flow of business. And if that person can't be reassigned and the flow of business, it doesn't improve, ultimately the employer has the ability to terminate that employee. And then the final change, shockingly enough, that we were able to get in there is to require that it did not apply to that it did not require, or that it did not work with emergency medical treatment for patients. That was originally in the draft language of the bill. So because the sponsor had, accepted all of those changes, we kind of stepped back along with a number of our, stakeholder and friendly colleagues, and just kind of took a neutral position on the bill. And so, yeah, it was signed into law in March, and we're continuing to kind of assess any impacts from folks, and have yet to hear anything yet. And then the final set of topics, immunizations, and just, in general, still a lot of lingering COVID resentment and pushback. The first bit coming with this gene therapy piece of legislation that was introduced pretty early in the session. It would have put a 10-year moratorium on human gene therapy products in Idaho. That includes mRNA vaccines. No one can administer, no one can receive for 10 years. We worked with a number of, well, actually, I should say that the legislation was scheduled for a committee hearing, and we had caught wind of that in advance, and we're able to have some conversations with some senators about just the silliness of this proposal. And that those conversations ended up paying off, and the committee hearing was scheduled. Instead of receiving a vote, it was just for informational purposes only. The sponsor of the legislation then took the information that was provided at the informational hearing and was attempting to have a second proposal come forward later in the session that would have put a 2-year moratorium on minors receiving mRNA vaccines. That was ultimately held off. I don't know if the committee chair, walked the sponsor back, but that ended up not seeing the light of day. I do expect to see a similar proposal come forward next year. We have some, information and educational bits that we kind of have queued up, and we're ready to deploy if that does happen. But yeah, pretty shocking legislation in all reality. The second bill, I think most everybody had probably heard of or heard about towards the end of the session. But it was this Idaho Medical Freedom Act that was introduced by Senator Dan Foreman up in Moscow. And it would propose changes to the vaccine requirements for schools, daycares, and businesses. It provided a very broad definition of medical intervention that many folks interpreted to potentially stop an employer from telling an employee to wash their hands or maybe wear a hairnet. And it also would have prohibited schools from sending sick children home from school or children that had lice and stuff like that. Ultimately, the governor ended up vetoing that piece of legislation. And shortly after that, within days, that the original sponsor tried to make amendments and changes to the bill that were concerns of the governor's, and ultimately got that bill introduced, heard, and made its way through both chambers and ultimately signed into law. From the attorneys that we have had conversations with, the changes end up kind of turning it into a nothing burger. Although there are some organizations, conservative organizations, that are claiming, victory and saying that it changes a lot. So most notably, though, the changes allow the schools to send sick children home, both in the school and the daycare setting. And it also aligns with school medical mandates and parental consent legislation. So that was signed into law in April, first week of April, and takes effect July 1. And that is it.
I will just say, oh, sorry, go ahead, Mike.
No, I'll let you.
I was just gonna say, that's seemed like a lot, but only it was just a sliver of what was going on. More than happy to answer questions that folks may have about bills that were not covered. So feel free to put it in the chat or raise your hand, and Katrina can help with that. But one thing I do want to say is that this year we had the highest number of bills that I can remember. I want to say this was maybe my 17th session, and we've never seen this many bills. I want to say there were maybe over 800 that were introduced, which is higher than I have ever heard of. So there were quite a lot of things that were out there. So if there was a bill that you heard about or have questions about, feel free to flag those for us. And I'll give folks a couple moments to do that. But in the meantime, I will say it was a hard session as you're hearing us describe these really harmful bills. But I will say, on a positive note, I was very encouraged by finally the general acceptance and folks actually mirroring to us their understanding and acknowledgement of the physician workforce challenges that Idaho is facing. Believe it or not, that has actually been something folks have been skeptical about for a couple of years as we have tried to make that case, specifically with respect to our women's health laws. But this parental consent laws and the restrictions on physicians and other providers being able to intervene and provide care to kids in very difficult situations is also having an impact on the attractiveness of Idaho as a good place to practice medicine, and just the threats against the criminalization of evidence-based healthcare. So we consider that a positive, that we at least get acknowledgement of the problem. And I would also say another positive was that we actually did stop a number of very harmful bills. And as Mike and I have given you examples of bills that started out to be very harmful and then were ultimately moderated. And so their actual impact, hopefully, it will not be as harmful to patients as it would have been. And I can actually give a couple of examples of that. One bill in the realm of women's health that was introduced earlier in the session would have taken some common drugs that are used for miscarriage management. It's a combination of mifepristone and misoprostol, would have put both of those drugs and considered them as Schedule III controlled substances. So it would have made it very much harder for healthcare providers to access those drugs for urgent situations in which a patient is experiencing a miscarriage, bleeding, and other types of situations. And in addition, it would have required those drugs and the recipients of those drugs to be entered into the state controlled substance prescription drug monitoring program. So basically creating a database of patients that have to use these drugs, not only for pregnancy management, miscarriage management, but also some other non-pregnancy related issues as well. So that was something that was very problematic that we were ultimately able to stop. So I'll pause there. Any other questions or thoughts that folks have?
And I'll jump in real fast.
Please.
Back to what Susie was saying, there's a number of other bits of legislation that come forward that we didn't highlight. I'm putting into the chat just an end of year kind of review and legislative report that we put together. And it has a lot of the information we covered here today, but some of the other bits and bobs that we weren't able to get to. So feel free to take a look in your free time, but a pretty thorough analysis there.
Great.
Thank you both very much. And thank you so much for your work. I know it was long and hard, and it is really appreciated. And I appreciate, Susie, I appreciate you pointing out the positives. It's easy to lose sight of those in times like this, I think. And reducing harm is so important. And we have to remember that that's an outcome as well. So thank you very much.
Absolutely.
Any other questions? Does anybody have any questions? Okay, if not, we will let everyone go. Don't forget to record your attendance if you want to claim credits and complete our evaluation. Thank you so much.
Thanks, Katrina. Thanks, everyone.
Thank you. Have a wonderful day.
You too. Bye-bye.
Bye-bye.